if it's okay, I'll get things started. So thank you all for joining us this afternoon for this virtual session on exploring specialties in medicine. This is being hosted by the Johns Hopkins Diversity Postdoctoral Alliance Committee, DPAC, and we have a wonderful pair of panelists, and I guess I'm one of them as well, who will each be giving small introductions about themselves, their paths into medicine, and a little more information regarding their own specialties. And I'm sorry, my dog is chewing her bone behind me, so apologies. So today we have Dr. Stanislaus from the Department of Anesthesiology and Dr. Fletcher from the Department of Urology. I'm delighted to be moderating this event. Just as a quick introduction, my name's Sam. I'm a third-year medical oncology fellow and current chief fellow at Hopkins. I'm originally from Yonkers, New York, for whoever may know where that is, and came down to Baltimore for residency and now for fellowship. My clinical interests are in lung cancer, and my research is focused on clinical trials utilizing immunotherapy in early stage lung cancer. I have been asked to remind you all to connect to the DPAC HBCU Mentoring Program LinkedIn page to follow any upcoming workshops. You can also visit our YouTube channel where you'll be able to find recordings of prior workshops. This workshop will also be recorded as well, except for the Q&A session, which will be happening after each of the panelists present their slides. And we're excited to answer any and all of your questions. I also have some prepared questions that we can ask to kind of spur the discussion. And so with that, Melanie, if you don't mind, I can, let me get this and here. And you tell me when you would like me to advance. I'm going to mute myself, okay?
Okay, thank you. So good afternoon, everyone. My name is Mellany Stanislaus. Currently, I have a bit of a hybrid role here at Johns Hopkins. I am both an obstetric anesthesiologist and also a postdoctoral research fellow to the Department of Anesthesiology and Critical Care Medicine. So you can advance. So just to begin, broadly speaking, I am an anesthesiologist, and then I went on to do additional training in obstetric anesthesiology. So just as a brief overview, anesthesiology, that specialty, it entails the use of medications to provide amnesia, pain control, and to facilitate the ability to perform surgeries and procedures safely, and in my case, also labor and delivery. Advance. So obstetric anesthesiology, that is the comprehensive management of women both during and after pregnancy. Actually, in recent years, our role, our scope of practice has broadened a bit, even to optimize patients during the antepartum period. More popularly, you hear about the use of epidurals for labor pain, but we also take care of women when they have to undergo deliveries under general anesthesia. Next slide. So how did I get here? So very long road, 12 plus years of training. I'm not sure where everybody in the audience is currently, but I'm kind of going to do a brief step-by-step. And with the understanding that you may have a non-traditional pathway. So 4 years of medical school, and later on I'll kind of talk about each of the institutions I attended and my path. More often than not, 4 years. However, you can, I know, take post-bac years to complete some of your medical school prerequisites, which I did. Medical school then for 4 years, and after your classroom years, you'll take a step 1, step 2, then anesthesia actually is broken down into both categorical as well as advanced residencies. The difference between the two, categorical is 4 years, has an internship embedded in the program of your choice, whereas with the advanced training programs, you would do an internship elsewhere or in a different specialty, and then continue on in your 3 years of a focused anesthesia training. Within that, you also have several exams. After your intern year, you'll take step 1, several in-training exams, kind of just checkpoints. And then you'll start your board certification, which is the basic exam. After graduation, you'll take the advanced exam. And then after that, if you so choose, you can opt to do a specialized, additional specialized training, which I'll also go into. And that is what is known as fellowship. That's 1 to 2 years. Within that time frame, you'll also continue your board certification through written boards as well as oral boards. And then finally, the end step, the ultimate prize is attending. And then in my case, I guess I've continued on in my training, and you can opt to do research if you so choose, or get an additional fellowship, or get additional specialty training. Despite the time, I always encourage people that if you're passionate about it, try not to focus so much on the time that it's going to take, because those years are going to pass anyway. And that's the quote I have up there. Is one of my favorite quotes. And also, as you're kind of moving along this journey, to really try and collect mentors, people that can speak truth to you, obviously truth in grace, but also to kind of steer you, because training can be very rigorous. So people that know you, people that support you, and people that can help guide you or refocus kind of on your North Star, your passion that you cultivate. Next slide. So the subspecialties that I was referring to, what I did, obstetric anesthesiology, there are several that you can choose, acute pain or regional. There's addiction medicine, cardiothoracic, chronic pain, critical care, neuro, and then pediatrics as well. So anesthesia truly is very broad, and you can tailor it to what your interests are. Next slide. So the anesthesiology care team comprises several people, several team members. It's led by the attending anesthesiologist, fellow, a resident, and then sometimes you also work with nurses, CRNAs, or certified nurse anesthetists. Next slide. So a little bit more into my background. I'm originally from New York, so I appreciate Dr. Rosner's roots, heritage, and then I was there for about 18 years. High school, college. I got a Bachelor of Science and a Spanish minor from the Georgia Institute of Technology. I then took some time off, actually, just to get some additional coursework done. And during that time, I worked in a doctor's office, and then I decided to actually go abroad for a year to kind of make better use of my Spanish minor. When I came back, that's when I started medical school. I was at Morehouse School of Medicine for 4 years. I actually initially thought I was going to be a surgeon, so I matched into general surgery, did an internship up in New York, and then changed my mind, so reapplied into anesthesiology at The Ohio State University in Columbus, Ohio. And then last year, I completed my obstetric anesthesiology fellowship, and now have stayed on in the hybrid role that I mentioned, both as an attending anesthesiologist, and also now completing a research fellowship, which has given me an opportunity to kind of get a better foundation for some of the research that I'm interested in. Next. So why did I choose obstetric anesthesiology? So something that's really important to me is purpose within what I'm doing on a day-to-day basis. And I felt that obstetric anesthesiology not only afforded me the opportunity to render care through tangible means, through the procedural technical aspect. It also keeps me on my toes, so it presents a challenge, and it's very gratifying, really important for me to find purpose in my work, as I mentioned. So I have the opportunity to take care of 2 lives, essentially, although the bulk of my practice focuses on the maternal care, but still very important. How you take care of a mother also actually has a significance in how the baby does. And then specifically, which speaks more to my research goal, is the maternal morbidity and mortality crisis. As you may or may not have heard of, minority women tend to have poorer outcomes, are 3 times more likely to die during childbirth, which is unacceptable. So that is what the bulk of my research focuses on now, trying to develop more so quantitative measures to assess how mothers perceive their care, and that how that relates to their outcomes. Next slide. And then this is just a picture of the procedural aspect. This is what we tend to be more famous for: epidurals, spinals. This QR code, if you're interested in just seeing a bit more, this specifically should take you to one of our societies, the Society for Obstetric and Obstetric Anesthesia and Perinatology. Kind of gives an overview of some of the things we do as obstetric anesthesiologists, if you're interested. Next slide. So the good, the bad, the ugly. So I would say, I wouldn't necessarily call it a con, but more so a challenging aspect of obstetric anesthesia is the acuity. The tone of labor and delivery can very quickly change. I tend to say that usually when things are going well, they're going very well. You have a happy floor, everybody has an epidural, everybody's pain is well controlled. And then you can get someone direct admit from the ED who needs an urgent delivery and you really know nothing about them. Perhaps they've come in from an outside hospital, maybe they recently moved and they're in essentially dire straits. So you have a very limited amount of time to gather history and then to deliver them quickly. Obviously working in a multidisciplinary team with the obstetricians, with your maternal fetal specialists to take care of mom and get baby out safely. So I think that's the biggest challenge, really being able to have essentially an equanimity, being able to move quickly, honing in on your procedural skills, and knowing when you need to either put a mom to sleep or whether it's safe to put in a block. I think also specifically at Hopkins, we don't take care of what can be termed bread and butter cases. A lot of our patients do indeed have systemic disease. So being able to balance all those systems safely. I'd say in terms of things I wish I knew, because I had a bit of a non-traditional pathway because I started in surgery, I do wonder sometimes if I knew more about anesthesiology up front, if I would have actually chosen this specialty first. So one of my recommendations is immersion, really during these years, whether it's pre-med or medical school years, to find someone that you can shadow. I know the pandemic kind of put a limit on what you could do, but ask anyone. The worst they can say is no. And usually most attendings, even fellows, are willing to kind of take you under their wing and just talk about what they do on a day-to-day basis. And if you don't see it, then you don't really know what there is to what the field has to offer. So if you can, I would even send cold emails, pull up programs, pull up the faculty at respective institutions and say, hey, I'm interested in this. Do you have any opportunities for shadowing? Can you, bring me into your field for a day so that I can see? And even if they are not able to, usually they can actually refer you to someone that can. So during these years, when you have the opportunity to see without the responsibility, take advantage of those times. And I'm open to questions if you have any.
Perfect. Thanks so much. And thanks for sharing your email too. I should have done that on my slides. So Dr. Maynard, do you want us to do questions all at the end, perhaps? Yeah, we'll keep going. Perfect. Love it. And so I will get slides ready for Dr. Fletcher. And so whenever you're ready, Sean, feel free.
Sure, yeah, I can start. So I am Sean Fletcher. I'm one of the fourth-year residents here in the urology program at Johns Hopkins. So I just wanted to give a brief overview of the field of urology and then also go into a little bit how I got into it, some other details about urology as a job, et cetera. You can go ahead and advance the slide. So what is urology? So, the textbook definition for urology, looking it up online, essentially, it's a specialty that is focused on the surgical and medical management of diseases of the urinary system and reproductive organs. I put an asterisk here and you can advance one more. There you go. That, our patient population is quite diverse. I think that probably one of the biggest misconceptions about urology is that we treat only adult, older men, which while that's certainly an important demographic, it's not the only only one. So as you can see here, you know, these are all types of patients that we see day to day, from very young to much older, both men and women. And there are urologists who only see women, for example, some who only see those in the pediatric age. So there's quite a large variety in terms of the patients that we treat. Go ahead and advance. And in terms of the conditions that we treat as urologists, so again, you know, even though urology is a surgical subspecialty, you know, focused on a few set of organs, there's actually quite a range of pathologies that we deal with day to day. So, you know, just a list here of the major ones. So, you know, cancer, whether the prostate, the kidney, the bladder, testicular cancer, and some rarer cancers as well. Any type of voiding dysfunction, so difficulty with urination in males or females. All sorts of congenital defects. So, you know, pediatric urology is often dealing with infants, you know, young children who are born with certain defects of the urinary tract that need to be surgically repaired or managed. Male infertility and sexual health is a big part of urology, and some urologists specialize particularly in that. Of course, kidney stone disease, something that affects a lot of people, you know, around the world. One of these pictures at the bottom left is, you know, someone doing a kidney stone procedure in the operating room. All sorts of traumatic injuries, sequelae from other types of cancers or radiation that can impact the urinary system, and even kidney transplants. So this is sort of just a comprehensive list of the things that urologists do that you may see in the hospital. And honestly, to me, it was quite a surprise to see sort of the wide range of procedures and pathologies that we treat as urologists. You can advance the slide. So the roadmap, you know, again, similar. It's you know, not a short road. It's a fulfilling one, but it's can be a bit long. But you know, after undergraduate years, you know, you go to medical school. That's, you know, 4 years, give or take, one or more if you're doing some extra training, extra degrees, etc. Urology residency is typically 5 to 6 years. So some residencies like Hopkins have a dedicated research year, which I'm currently in. That makes it a 6-year program. But many are 5 years around the country. And then again, just like you just heard with anesthesia, there's the opportunity to do, if you want to, an optional fellowship, which would allow you to specialize in one of the you know, subdivisions of urology that I talked about in the earlier slide. And I think one important point about urology in particular is that it's a little bit more of a niche field that many people, as we're coming up through our training and, you know, high school, undergrad, don't really get exposure to. So most people, including myself, did not really find out about what urology was until they're, you know, almost halfway through medical school. So I think that's an important point when it comes to, you know, we just talked a little bit about exposure, trying to get yourself out there and see different things. And it can be a good thing because you may end up falling into something that you end up loving, but didn't know about prior. You can go ahead. So just a little bit about my personal journey. So I am from South Florida originally. That's up at the top, little red star there. I, you know, went to large public schools throughout most of my schooling from K to 12, and then went to Yale for undergrad. While in undergrad, I sort of got into the idea of going to med school based on a bunch of different things that I did there. So, you know, I did things like play soccer, but I also did some basic science research. I did some work with a group called Community Health Educators, going out into public high schools and sort of giving a health curriculum for schools that did not have one. I worked at a free clinic and did a few other, you know, things related to community health. And I think that brought me to med school. I ended up attending Harvard for medical school. And that's where I ended up finding urology. Actually, initially in my first couple of years, I was very interested in medical oncology. And so did some, you know, cancer research my first couple of years. And then honestly, on a whim, you know, during medical school, you rotate through several different specialties. So you spend a year essentially in the hospital, working as part of a team, and, you know, everything from anesthesia, OBGYN, internal medicine, pediatrics, et cetera. And on my surgery rotation, I sort of randomly was assigned to urology. I wanted to do something else initially, I think transplant surgery, and that was full. So I got put in urology. I ended up really loving it, which, you know, I'll give some reasons for that on the next slide. But I'm currently here at Hopkins and I'm past the halfway point of residency. So, you know, making it through to the end. You can go ahead and advance. So what drew me to urology? Yeah. So, the first thing I think was the patient relationship. So I think we're fortunate in urology to be able to take the patients who come in with an initial diagnosis, take them through a workup, take them through, all the different studies that need to be done to work up a problem, treat the problem, whether that be through prescribing medicines or doing surgery. And of course, urology is a surgical specialty. Being in the operating room is a big part of what we do. So the top right here, just some representative photos of robotic surgery. We use a lot of really cool cutting edge technology, on a day-to-day basis when we're in the OR, being able to work in a team setting. You heard a little bit, we work closely with our anesthesia colleagues, of course, and, there's a whole team of surgical nurses, circulating nurses, scrub techs, et cetera, who help us really, treat these patients and do these complex operations. And then, urology is a great field. Like, many things in medicine, we have the opportunity, especially at a place here like Hopkins, to do a bunch of other things outside of clinical care. So, research, education, community outreach, advocacy, leadership. These are just a few of the things that we get exposure to and get to be really involved with as physicians. And certainly in urology, there are many opportunities to do that. I personally, I'm very interested in research in urologic oncology, as well as community outreach, advocacy, all of these things. So these are sort of really great adjuncts to our job to be able to, help us treat not only the patient in front of us, but also the larger community. And then lastly, the people. I feel this is just a picture from when I was back in med school, a urology group that I worked with, where we focused on researching health disparities, specifically in prostate cancer and bladder cancer. And I think one thing that drew me to urology was the people that were in the field and sort of who guided me as mentors were, very hardworking and intelligent, but also down to earth, able to, sort of have a lighthearted nature to themselves and didn't take themselves too seriously, but were also, very dedicated to treating their patients and getting their jobs done. You can go ahead and advance. So I'm a numbers person, so I just threw out some numbers from the urology census, just to give a ballpark idea of what the job looks like. The median salary listed here can vary quite significantly based on where you practice, the type of practice setting you have, and many other factors, but just threw that up there as a ballpark. Similar to what you heard before, there's the option to do fellowship to subspecialize. So about 40% of people do that. About half work in private practice. There's a median number of hours worked per week, although that can, again, vary quite significantly depending on the person. And I think the last bullet point is the most important one to me, and I think one that I see day to day. The vast majority of people who end up going to urology, if given the chance to, choose a specialty again, would still choose urology. So I think that sort of speaks to, the overall happiness in the field that people have. You can go ahead and advance. Yeah. And just lastly, I wanted to touch on the fact that, one big gap I think we have in our field, as we have in medicine in general, is just the need for better representation. So on the left here is a graph showing over the years, the percentage of women in urology, which although it's steadily increasing is still quite low at only about 11% of practicing attending urologists who are women. More reassuringly though, there's a larger sort of influx of women in the pipeline. So now close to a third of urology residents around the country are women, which I think is an encouraging sign for trends to come. But still, urology definitely lags behind in terms of the percentage of underrepresented minorities, Black, Hispanic people entering the field. And so I think these are all things that we as a field need to be working on. At the bottom, I just threw up a couple of different organizations within urology that are actually wholly dedicated to this cause. So Society of Women in Urology, the R. Frank Jones Urological Society, which is dedicated to increasing the amount of representation of Black physicians who go into urology. R. Frank Jones is actually, just a tidbit of history, was started one of the first urology training programs for Black medical students at what's now Howard University Hospital. So, all that to say, this is going to be a big sort of issue going forward in urology. I think that we're really trying to increase the pipeline into our field. And I think it's something that you guys should definitely consider when you're at the point of looking into different specialties to apply into. Great. And then I just have my email up there.
And Twitter, that was good.
And Twitter, yeah.
Thank you so much. I will stop sharing that slide and I'll share this one. So apologies, my slides aren't as wonderful as the other panelists, but we'll hopefully get the job done. Anyway, so again, my name's Sam. I'll be talking a little bit about medical oncology and my road into this field. It's a busy slide, but this is my road. As the other speakers spoke about, it is quite a long journey, and various people can take different paths. I knew I wanted to be a doctor early on in undergrad, and so did kind of the quintessential pre-med track. Although there's certainly opportunities if you find out later that you're interested to do post-bac and so on and so forth. I did my undergrad at Stony Brook. Again, shout out to New York. And during that time, I was just really fortunate to get a position in a research lab at Sloan Kettering during the summers. And that was my first exposure to like science and specifically to oncology. It was an oncology research lab at Sloan Kettering. And I have photos here of all the mentors who kind of helped me along the way. And so another point that I really want to drive home is mentorship and finding really great mentors. I used that experience to kind of further and hone my interest, knew that I wanted to get and go to medical school, and was fortunate enough to get into Albert Einstein College of Medicine, which was close to home, which was great. It's in the Bronx. Again, you kind of spend the first 2 years of med school just learning a little bit of everything. And then that third year is really critical where you're getting actual time in the hospital, in the clinics, to almost sample which specialty you'd be interested. And I tried to go in with an open mind, but still kept finding myself interested in oncology and understanding that oncology was a subspecialty of internal medicine. I was drawn to internal medicine. And so then applied into residency for that and did my residency at Hopkins Bayview. And, you know, there's a lot of different branches from internal medicine, which I think is one of the cool aspects of it. So even though I had an interest in oncology, I knew that I still had opportunities if I, for some reason, was interested in critical care or cardiology or so on and so forth. So you still have the opportunity to further differentiate from there or go into general practice and be a primary care physician or a hospitalist. So I think internal medicine was nice because I knew I was kind of continuing on the path that I thought I was going on, but I still felt like I had opportunities to branch out. But ultimately, I did want to go into oncology and applied and stayed at Hopkins for fellowship. And again, what I'll say is that there's been wonderful mentors along the way. The first, clinic I shadowed in was during undergrad with Mike Postow, who is now a melanoma expert. And it was just by luck that I got into his clinic. But without kind of having that shadowing experience, I wouldn't have had an in-depth view of what certainly being a doctor is, and then specifically being an oncologist is like. And it was that those experiences, seeing the wonderful stories from patients, the relationships that oncologists have with their patients, that really drove me and was a unifying force for me as I was kind of going through this path. I'm actually going to be attending next year and joining the lung cancer group at Maryland, and where I'll continue to have wonderful mentorship from people like Dr. Mayra, who's here on the top. And so again, finding really generous mentors with their time, those who are approachable and those who prioritize you is really critical. Why I chose oncology, I already referenced it a little bit. The relationship that you have with your patients, I think, is so incredibly unique. Patients are coming to you in their most vulnerable hour, and you are there to help them, whatever measurable way that is, whether that is getting them, to potentially cure or managing symptoms and trying to, unburden them in various ways. You're meeting with their families, you're meeting with their dog, you're meeting with every aspect of their life, and it kind of all comes together into the treatment plan that you provide them. You really are my wife is a primary care physician. I feel like I'm the primary care physician of the oncology team. And I don't want to take anything away from the surgical oncs and rad oncs. But yeah, I really do feel like the quarterback, the one who's kind of who's their go-to person when issues come up. And so I really liked that longitudinal aspect, as Dr. Fletcher had referenced as well in urology. I think your medical oncology in general is just an exploding field. It's incredibly exciting from a scientific perspective, from a therapy perspective, but also so exciting for patients. So every year I get to go and think about new ways that these therapies are going to help my patients. And there's therapies now that were not available literally just a few months ago. So that's really exciting. It's an exciting aspect in terms of research and kind of that intellectual curiosity that it offers. I like that I have a variety in my day where I see patients, where I'll be seeing patients, where I do research, where I can do things like where I can work on advocacy issues. You know, there's huge issues in terms of health economics for oncology care, as I imagine most of us are aware of. And you as a physician have a voice in that if it's of interest to you. And then finally, you know, oncology is, as many fields, you know, very multidisciplinary. You are developing very personalized plans for each patient. So even though there's guidelines, a real expert kind of works within those guidelines and fits it to the patient. And that's with your surgical oncologist, your radiation oncologist, your palliative care team, your social worker, et cetera. So it's a really exciting field for all of these reasons. And I've been fortunate to be continuing to learn and be a part of it. So if you're interested in medicine, these are kind of very obvious, maybe obvious things that I'd recommend. Gain that exposure if you can. Consider shadowing. I actually think that that's a really hard barrier for some people. Yeah, I didn't have any doctors in my family, no doctors in friends' family. So actually getting into a clinic was kind of hard. So using platforms like this, emailing any one of us, feel free. We're happy to either arrange for you to shadow me or one of my mentors, is a really great way to get hands-on experience, at least to get a sense of whether this is something you may be interested in. And then kind of use that to build contacts within the field. And so that kind of leads to the second thing, which is identifying mentors. And so I would not be where I am. I wouldn't have gotten to each step without the mentors that I put on that page, who, again, were so selfless and generous with their time. And you'll need mentors kind of throughout, and you'll need multiple mentors for each aspect of your training. And then finally, and this has been spoken about before, realizing that it's a marathon and not a sprint. There's going to be times where you get discouraged. It could be little things like doing poorly on a test, or you know, something not going well, something very discouraging for a patient if you're in the clinical aspect of your training. But understanding that if you persevere, if this is truly what drives you and what interests you, you know, it kind of taking that long view, because it's certainly a tough road, I will say that, but very, very, very rewarding. And I think that was it. So with that, I thank Dr. Stanislaus and Dr. Fletcher once again. And I think if people have questions, feel free to put it in the chat.